Ajay Kothari is a medical graduate from Pune University. He has stood first and attained distinction in all his 4 years of his graduation. He then went to do his post graduation from Sancheti Institute of Orthopaedics and Rehabilitation. He passed his DNB Orthopedics and stood first all over India and was awarded Dr. Balu Sangram Gold Medal for the year 2008. During his tenure at Sancheti Hospital, he got the Best Resident Award. He got extensively trained in advanced spine management in Mumbai, Coimbatore, Germany, USA, Netherlands. He was awarded the prestigious SRS, that is Scoliosis Research Society USA Traveling Fellowship for the year 2014, and visited the renowned spine centers in USA as a guest surgeon. He has been elected as a committee member of SRS USA and a member of AO Spine Swiss. He is specially trained in spinal degenerative conditions, non-operative treatment for spinal alignments. Dr. Kothari, sir, is pioneer in robotic spine surgery in India. He is the first one to use the latest O-arm and neuronavigation technology in the country. He has devised and patented 3 surgical techniques to be performed in the tuberculosis of spine surgeries, which has gained world recognition. Sir has published over 26 publications in the world literature, which was quoted widely in the spine surgeons all across the globe. Dr. Kothari has a social touch for poor and needy patients. He visits Amannagar twice a month, Jalgaon, Samanta, where he conducts free charity OPD and free surgeries for poor and needy patients. Sir has trained approximately 65 spine surgeons till date from all over the country. It's a great honor to welcome Sir for this lecture. Over to you, sir. Thank you.
So, hello everyone, I am Dr. Ajay Kothari. I am a consultant spine surgeon at Sancheti Hospital, Pune. Although I call myself a surgeon, I firmly believe that 99% of the spinal problems can be treated non-surgically. Only 1 to 2% of patients, they need any form of intervention. So when I say that, I strongly believe that there is a big role of non-surgical treatment as far as spine problems are concerned. When I say non-surgical treatment, it all begins with a preventive treatment in order to prevent, these lifestyle diseases to happen. And if at all they happen, then there is a big role of physical therapy, that is physiotherapy, to play in it. And in my practice, I very closely work with physiotherapists because 80 to 90% of is done basically by physiotherapists, because my people need any intervention to a good physiotherapist. And the role of that physiotherapist is to guide the patient about ergonomics, postural training, core stability exercises, all do's and don'ts, and keep in touch with that patient so that in order to, make that patient completely back to normalcy, that physiotherapist has to call that patient at regular intervals and increase the level of exercises. And that's how I firmly believe that spine patients should be treated. As you all know, spine is a very complexly, situated organ, and the anatomy of the spine is such that it is a very thin, very delicate organ, and little messing up here and there leads to disastrous complications. So when we started our spine surgery career, it was a very challenging phase because spine surgery, first of all, was in big disrepute. Everybody used to ask me, whoever I used to say कि आपको surgery की जरूरत है, तो the first question patient used to ask was, doctor, क्या मुझे paralysis होगा क्या मेरा चलना फिरना बंद हो जाएगा क्या? So I always used to say, no, in today's era, with advancements in technology, with advancements in infrastructure, with advancements in surgical skill and ongoing training programs, spine surgery today has gained lot of momentum, and the success rates have increased drastically to the tune of 99%. So when I say so, what has happened in last decade or in last 5 years that has really led to increase in the successful outcomes of these surgical patients? So the talk what I'm going to give today is based on 6 things. First is OARM and navigation, that is the intraoperative CT scanner that we have, the OARM. The second part is a neuro navigation, which we use in coupling with the OARM. Third thing is neuro monitoring. So it is an intraoperative spinal cord monitoring, which is there so that electrophysiologist is constantly sitting and monitoring the spinal cord when I'm doing the surgery. Fourth thing is ultrasonic bone scalpel. So whenever we do any laminectomy or bony cutting, there is a ultrasonic bone scalpel that gives us a precision and it doesn't injure any of the neural structures. Fifth thing is all these high-end microscopes, 3D, 4D microscopes which have come up. Sixth thing, which is very relevant, are these keyhole spine surgeries. And we proudly say that, we are again becoming one of the biggest centers as far as doing these endoscopic spine surgeries are concerned. So that patient goes home within 24 hours. Patient need not stay in the hospital beyond 24 hours. So these are the 6 things that I'm going to base my talk upon. So thank you very much, team Mimer and Dr. Ravinder, for inviting me for this talk on recent advances in spine surgery. I head the spine unit at Sancheti Hospital, Pune, and we are one of the biggest spinal unit in the country. And we cater to almost, surgically cater to around 2,500 to 2,800 spine surgeries per year. So with this background, let us start with, my talk. And that's the thing, that what are the recent advances in spine surgery and use of artificial intelligence in spine surgery. AI is the most popular word today, maybe any field. And how can medical field and spine surgery lag behind? So it won't. So artificial intelligence is grossly used in today's era. And with the use of artificial intelligence, the spine surgery success rates have again shot up tremendously. So first thing that, I'm going to talk of, the latest advancement that has happened is this OARM and navigation. So let's start with what is OARM. The OARM is a portable image device that provides real-time images of patient's anatomy during surgery. So in short, it is a CT scan within the operation theater. So the OARM navigation system is a computerized 3D navigation system that scans the spine during the surgery. And these images which are acquired, so I'll give you an example, how we operate a patient using OARM and navigation. So the patient is given anesthesia and the position is given. Say, for example, I'm going to operate a complex cervical spine tumor. So what we do is that part, we take a scan. That scan lasts for around 18 seconds. After that scan is taken, these images are transferred to the navigation. And when I'm going to operate that particular patient, I exactly see where the problem is and I can put my implants accordingly where I wish to, whether the laminectomy has been done properly or not, whether the tumor has been completely removed or not. Is there any pressure which is present on the spinal cord is still there or not, that I can see completely. So the benefits are OARM and navigation are surgical time reduction, reduction of radiation exposure for the surgeon, safety, a lot of accuracy, and it gives us good bony landmarks even in revision spine surgeries, even in complex deformities, even fractures, tumors, even in cases of infections where a lot of destruction of bone has happened. It really helps us a lot. So let's start with how we use this OARM and navigation in our operation theater. So let's start with this case. This is a 12-year-old female. She has a progressive deformity of back since 1 year, and she is known case of spina bifida and diastometamylia. She had undergone a resection and release of the tethered cord at the age of 2.5 years. So the resection was basically for the bony bar of the diastometamylia, and she had a tethered cord. She had a hairy patch. You can see these are her x-rays, and she had a hairy patch on her mid-back, left thoracolumbar curve with truncal shift and coronal decompensation. The Cobb's angle was around 80 degrees. So these were her x-rays. You can see she was grossly decompensated. This is the straight line, and you can see her left shoulder higher up, right shoulder lower down. And you can see CSVL is 46 millimeter away from the center of C7. So this is C7 and this is CSVL. So you can see usually this C7 should lie just above this central sacral vertical line, but you can see the amount of decompensation that has happened. And these are as MRI images. You can see this is the old surgery done for her diastometamylia, and this is the tethered cord release done here. Now I was mentioning about how we do these surgeries. So you can see the thin pedicles. Initially, when I had to operate these patients, we used to have sleepless nights because there is a thin pedicle, and I have to put my screw in this thin pedicle. Now, this OARM and navigation comes to our rescue because you can see the deformed, rotated pedicles here, and putting a screw here in order to get a correction, you just get one chance. And if you go medially, you hit the spinal cord and patient gets paraplegia. If you go laterally and anteriorly, you hit all the major vessels like inferior vena cava and aorta, and it can lead to disastrous complications. So you just have a 7 mm thin bone and you have to put your screw through that. And initially we used to do it freehand, just with our 3D orientation of the mind, and we used to put the screws. It's not that we were going wrong, but here the stress on the surgeon drastically reduces, and it really helps us real time intraoperatively in order to get a better screw purchase and good hold. So you can see this is the post-operative image of that girl, and you can see this is that girl whom we operated using this OARM and navigation technology. You can see her right shoulder was lower down, left shoulder was higher up. This was the initial surgical scar, and two scars. This was the diastometamylia release, and this was the tethered cord release. And doing surgery in a scarred area where there is already a laminectomy which is done is not an easy job, because even while dissection, you can go wrong. But you can see a beautifully performed surgery for this girl. You can see her both the shoulders coming at the same level. You can see her deformity getting completely corrected. So these are life-changing surgeries for these small kids who otherwise, because of these deformities, they get depression. They don't want to mingle with normal crowd. They don't want to go out, and they somehow lose their zeal towards life in midstream. So these are those surgeries which really gets these young kids back into active lifestyle. And I'm very proud to say that this young girl is a medical aspirant. She just cleared her 12th standard, and she is working very hard for a NEET examination. And she always tells me proudly that, doctor, because of your surgery and miraculous improvement in my case, I want to become a spine surgeon and do a similar job as you do. So that was one statement that touched my heart so much. And no amount of money or no amount of luxury can give you that sort of happiness, which a simple comment from this girl gave me. Coming to a second case where this intraoperative OARM and navigation helps us is this young boy again. This was a 13-year-old male, Again, he had a progressive deformity over his back. You can see the amount of kyphosis he had here. Thoracolumbar kyphosis with multiple vertebral anomalies. You can see this is a CT scan. So normally you have a cervical lordosis, thoracic kyphosis, and lumbar lordosis. So you can see here the amount of kyphosis which is present here. And these are his x-rays, and he has got a scoliosis also and kyphosis also. Now again,
Hello.
this is
So
how
you
it
can see
is.
we have done a T11 and T12 PVCR, that is posterior vertebral column resection. It was a big void which we eventually closed, and you can see this is a pulsating cord here. You can see again. You can see there is a pulsating cord here, and here is the place where we have done an osteotomy, and then we have closed this osteotomy and corrected the kyphosis. We have got a near normal collection of the kyphosis, and we are about to close. Thank you.
So with this OARM navigation, you can see initially how this boy was, and this is the post-operative X-ray, and you can see how this boy was pre-surgery and now how he has become post-surgery. Again, a life-changing event. So the best part about using OARM and navigation in this cases is we can exactly measure the wedge and take out the wedge in that particular deformity so that we can get a absolutely neo normal correction. Now using navigation in spine surgery. So what is navigation? So if you are living in Pune and if you want to reach somewhere in Pimpri Chinchwad to some street and to some lane, you just have to put your address in on the GPS, and that GPS takes you from Pune camp to Pimpri, or it can take you from Baner to Nigdi. So it can very easily take you there. Initially, what used to do? Used to ask corner ka pan wala, bhaiya abhi ye MG road kidhar hai? Then used to go further, used to ask some bakery shop, aiye bhaiya ye lane number 12 kidhar hai? And then used to go. It used to be a big trouble. But with the GPS, your GPS takes you where you desire to go. So similar thing has happened in spine surgery, and we use navigation. So in navigation, we can exactly reach the place where we wish to, and it takes us where we want to go. So this is how the navigation works. So the navigation, the screw accuracy rate tremendously increases, as is shown in this paper. It comes up to 95.5%. With a conventional fluoroscopy, that is CM, it is about 68.1%. So this is the tracker which is applied. So let's start with certain cases, how navigation helps us in our day-to-day scenarios. So a 33-year-old male, severe low back pain, VAS of around 8/10 with right low limb radiation, not better with conservative trial. You can see these are our standing X-rays. And these are the MRI images of this patient. You can see there is an L5 or S1, almost grade 3 to 4 spondylolisthesis. Now you can see how you get a good purchase in screw hold in these patients with use of navigation. This is a thin bone with which you have to put a bone, and you can see how you can reach very nicely using a pedicle screw here. Similar with this. This was the right screw. These are very important screws when we have to reduce a deformity of spondylolisthesis. And you can see this was the pre-operative listhesis, and this is the post-operative image where we have done a stabilization, we have done the laminectomy, and we have taken out the disc anteriorly and packed it with a cage. Excellent outcome, patient doing fine, and there is a follow-up of almost 2 years for this patient. Second case, patient 32-year-old female, severe low back pain with right low limb radiation. Again, you can see spondyloptosis. So you can see 5 vertebra is literally lying in front of S1 vertebra. These are one of the most challenging cases to be operated in spine field, and getting an implant hold here is very, very, very challenging. Now you can see how we manage to put screw here. You can see we go far laterally and you get only one chance, as I said, and then you put your screws in these completely dysplastic vertebrae and dislocated vertebrae. You, as I said, you only get one chance. If you miss that chance, then you don't get any hold and you have to go to higher normal level, which violates a normal level, which is L4-5. And you can see here, putting screw in S1 is completely opposite to that. So here we were here like this, and here we are here. So it is a very challenging scenario, but I think I must say we are lucky to practice in this era where in last 4 to 5 years, things have revolutionized so much that our success rates post surgery have increased tremendously. And you can see this is the post surgery image wherein a patient has got a very good reduction. There is a very good pelvic incidence, lumbar lordosis, sacral slope, pelvic tilt. And this lady is doing fine, living a very happy, normal life. Initially, what we used to do is we used to go higher up here, put a screw here, put a screw here, distract it, try to lever this out. So we used to dissect so much. But these are very easily possible now with smaller incisions because of navigation. Coming to the next case of tumor, you can see this is a young boy, 16-year-old male, and there was a thoracic tumor, you can see, and there is a complete cord pinching here. You can see this is a CT scan, and you can see this is a whole tumor which is eaten up here. So diagnosis was D8, D9 aneurysmal bone cyst with cord compression and myelopathy. So plan was D8 tumor resection with bone grafting and stabilization. This is application of reference frame. This is the how the O-arm comes in and takes the spin. And this is how it helps us during surgery. This is how, we can see the bony defect intraoperatively. These are the intraoperative images. This is the tumor cavity. This is after putting the screw, we are doing the laminectomy. And this is how we have taken out the tumor. Intraoperative check. And this is, we can see after the instrumentation has been done, we have taken out the tumor, we have packed the tumor with a bone graft, and we check the adequacy of tumor resection, bone grafting post surgery using this O-arm spin. You can see this is the post operative image.